Hello, welcome to our panel today. Thank you for joining us. I'm Dr. John Barbaro. I'm the Chief Medical Officer and Vice President of Ambulatory Services at Bergen Newbridge Medical Center in Paramus, New Jersey. We have a wonderful panel today. Hope to have a nice, robust conversation. So I'm going to start. My first question I'm going to direct to Carrie, and as I bring the questions to you all, can you introduce yourselves as well? Carrie, determining which service lines to target right now is a unique challenge, obviously. It can be very difficult to figure out, a specialty that's high performing might have reached its peak. You might have an underperforming area that has potential to it. In your experience, what are the best practices that should inform service line planning, and how do you cut through all of that?
Thank you, John. This Kerry Gillespie with CFO at Legacy Health in Portland, Oregon. There's a multifaceted approach to that question, but I think if you drill it down, the first thing is to kind of have an eye to the future. What is happening? Where are the trends moving? Because, like you said, a high performing revenues source today will not likely be or could not be a strong revenue source in the future. So you want to be looking at trends. You want to be looking at what things are happening in the area that you're serving. One of the things that we've taken a look at certainly is births and how births and obstetric medicine are changing. We're seeing a substantial decline, certainly in the fertility rate across the country, but it's more pronounced in certain parts of the country. And so taking a look at at what your services look like in births, and is there the ability to consolidate some of those services and actually do add-on services that could possibly, I think, augment the revenue that you get around your obstetric service. So strong pediatric service, for example, certainly gynecologic services and the approach to those. So there's a bunch of things that can be done associated with that. I think an important point to make is that making sure that you have the financial information to make these decisions is real important. Having a strong FP&A process where you can do service line analysis of financial information so that you can say, okay, this service line is performing well. We think it's going to perform well in the future. We need to expand our services there. Otherwise, and alternatively, you can look at other service lines that are not performing well. The payer mix is not where it should be or where you'd like it to be, and you don't see a move into the future. That service line should be managed down and eventually out. So it's just a matter of market, where you are in the market, what the market looks like, where the market is going, and then being able to capitalize on those opportunities for expanding current services and inviting new services in. Then the other point to make there is certainly physician availability and provider availability in those markets as well. Or do you have the necessary nexus of providers that can provide the care that's needed in that service line in order to expand it? It's hard to expand something where you have no physician services or the inability to recruit strong physician and APP services into that service line. So I'd say all of that is included in taking a look at that opportunity.
I really like a bunch of the things you said in there, in particular about seeing what spins off of some of the service lines you're building, right? I mean, do you do it solely? You talked about data. Do you do it solely based on data, or do you do a little bit of ear to the streets, or how do you determine that?
Well, we do it both ways, right? You have your own financial data, you have state and national information, and then we do focus groups as well. In certain communities, we'll pull a group of community leaders or community members and do a 12 or 15 person focus group to talk about what they see and what their needs are and what they anticipate their needs might be in the future. That all of that can drive a cohesive approach to it.
Bang, that's fantastic. I totally agree with you. Anil, I saw you nodding a lot during that. Do you
Sure,
want to introduce yourself and tell us your thoughts?
sure. I'm Anil Jain. I'm the market CFO for Scion Health in Texas market that just became effective by next week or so. One of the things we kind of looked at it in our hospital is that we had a 50-bed forensic psych unit,
Mm.
which is a really good unit for us because we get a capitation. So we get a monthly payment from the state for these forensic patients. And we also had an inpatient psych unit. So we're in the process of closing the inpatient psych unit and adding maybe 10 more forensic bed.
Mm.
Uh, and that will allow us to add additional revenue for us. And whereas we'll cut down having to deal with the managed care payers and the contracts for the psych units, and our census is very low on the inpatient psych unit. So I think this is an opportunity for us to even expand our forensic beds from 50 to 60. Also, it's not going to impact the staffing. It's going to definitely cut down our hassle with reimbursement and that type of thing. And it's a steady income. We get a monthly payment, and it's almost a capitation model. So we're not really concerned about keeping the unit full. So if we have less patients, that's fine because our costs will be lower. So that's one area we have really expanding our forensic service. And also it's a needed service because as we know that not many people have this resource available. So I think we're being a good partner in the state and providing the service and expanding the service to meet the community need.
I think that's great. I couldn't agree with you more. I think the last several years have proven to everybody how important mental health is and how it ties in with
Mhm.
physical health. I'm an internal medicine doctor by background, but
Sure.
it's just so obvious of how it all kind of fits together. We actually have a large psychiatric service here at our hospital as well. And one of the other things we've found, I totally agree with you that there's been a push away from the inpatient side and even also more towards outpatient treatment of behavioral health. Have you seen that at your facility as well, in addition to the need for forensic beds?
Well, unfortunately, we don't have the resource from the psychiatrist standpoint to offer any outpatient services, which also the reason we don't want to be inpatient because we don't have patient to transition to another next level of care. So we do not have the psychiatrist bandwidth to offer that type of service or mental health professionals. So we do not
No, that
offer any outpatient services.
no, I understand there's obviously a massive shortage across the country. But one thing we've been successful in is fortunately we've been able to recruit psychiatrists and use other methods to supplement it. But we've also found that then has become a driver into some of our other services because patients come in for mental health and then those two things tie together. Just but not just in mental health, but just talking in general. I mentioned I'm the VP of ambulatory services, so outpatient tends to be something that is of interest to me in general.
Mm.
So I'm going to turn this over to Ron next. What's your strategy with respect to expanding your outpatient and ambulatory footprint? What are you guys doing to build out non-traditional care models? There's so much stuff going on. Do you have any thoughts there? And again, can introduce yourself to the watchers.
Yeah, so my name is Ron Wade. I'm the Chief Nursing Officer and Chief Operating Officer at Sky Lakes Medical Center in Klamath Falls, Oregon, South Central Oregon. One of the areas that we're expanding, we'll just continue on down the mental health pathway. In a rural space, we serve a population of about 100,000 people. So it really is a rural space and even frontier space. Behavioral health has been one of our biggest challenges. And so we've kind of tried to do things twofold. So we always want our team members to continue to grow. So we've offered up scholarships for our nurses that were at the bedside to become nurse practitioners. And just by natural selection, we've had a number of nurse practitioners go on to become mental health nurse practitioners. And so that's allowed us to multiply our psychiatrists and expand our footprint in that outpatient space in psychiatry, as well as bring some interventional therapies that are non-medication based. So we are just getting ready to open in the next 6 months with a transcranial magnet stimulation therapies, as well as expanding on our ketamine therapies. That is more drug based, but that's how we're kind of growing into that space. From an outpatient ambulatory, also being in the rural space, we really are looking at how do we meet our community need. And so one of the things we've done is we've now just opened our fourth pharmacy because we saw that need there. And so 7 years ago, 8 years ago, we wouldn't have had any outpatient pharmacies. And now we actually have three walk-up pharmacies and one specialty pharmacy. And again, that was really to meet the needs. What we found out was that if somebody needed to go through a specialty medication process for those high dollar drugs, that it was up to 6 weeks to get those medications. And so when you're talking about oncologics and even some of the rheumatoid medications, that is a long time to wait for medications. So we stepped into that space, allowing us really to expand that footprint in that outpatient space, as well as in our primary care, because although we are a single hospital, we are a small system, essentially, and building a team model in our primary care so that we are using pharmacists, dietitians, even physical therapists in that space to help drive care. And it really comes down to managing the care. We're trying to move toward a managed care model to get to that PMPM, that per member per month, and really delivering well care and health care versus waiting for sick care.
I like a lot of the stuff you were talking about. We've actually done very similar things, interestingly. There were a few things you hit on there I wanted to ask about, and I don't know if anybody else wants to ask some questions too. First, I wanted to ask about the pharmacies, because we've actually had a similar experience. And so we're not rural, we're in a suburban area, but we're a safety net hospital. So we have some different but somewhat similar challenges. Have you looking into mail order pharmacy as well? Is that something you've all looked into, especially in a rural area? I would think that might be something useful, but I didn't know what your thoughts were.
Yes, we actually are looking into mail order, actually even pre-packaging. Just because, there's the long-term care, there's patients, because you can actually drive an hour and a half just to get to the hospital here, or to the pharmacy to pick that up. And so we are exploring mail order because that makes it easier on our patients. We don't want our patients to have to make the decision of, am I taking a half day off work just to go get my medications? When we can deliver that right to their door and ensure that they decrease the blocks to maintaining and adhering to the care plans.
I think that's great, and you hit a few times on kind of integrating care. You talked about the per member per month type model. Again, we've done a similar thing. I wonder though what your thoughts are, or what our other colleagues' thoughts are. Just there's been so much talk over the last decade or so of people moving towards pay for performance, and we haven't really seen it totally take hold. I think that for commercial payers, because most people get insured through their jobs and people change jobs, I think that there hasn't been as much push towards it as there originally thought there was going to be. I don't know what you or anybody else on the panel thinks about that, but we've actually found that for us, even without that model, it's been beneficial on a financial standpoint because of something you mentioned, which is that patients have difficulty coming in to do some of these things. They have to take off from work. They have to do anything else. We have had, for us, we've actually moved to doing shorter visits on the outpatient side, more frequently trying to use telemedicine to supplement inpatient or in-person visits in order to do that. And that's, even though the visits are shorter, they might bill at a lower level because there's more of them. It financially ends up working out. Have you seen anything like that? Or if not, I was going to turn it over to perhaps Kerry, but Ron first. I didn't know if you had anything.
It's interesting that healthcare is one of those last fields where we haven't adapted to the patients, right? Could you imagine if Amazon said, hey, you can only buy stuff from us on Tuesdays? Or, you know what I mean? And so we have done that. And that is where that integrated model is so important, because you can accelerate what are the physicians and the prescribers are doing by bringing those specialists. And actually, I think the patient gets better care because I don't expect one of my primary care providers actually to be there talking about leafy greens, right? I need a dietitian doing that. That is their specialty. That is their love. And so as we move down this pathway, that's building that team model out is key to decreasing the length of visit with a provider, but also increasing interactions with the healthcare specialists.
Absolutely. Kerry, you were nodding pretty vigorously through a lot of that. It seemed like you wanted to jump in.
Thank you. So, yeah, one of the things that we've done as an organization is really dived into the pharmacy space, right? Most of our facilities are 340B hospitals, and so every facility actually has an on-site pharmacy. We've been very proactive about patients that need medication when they leave the hospital as inpatients. We've got like Ron said, we prepackaged some of this medication for them, so they'll have their medication when they get home. They can jump right into taking their prescriptions according to the prescribed prescribing work done by their physicians. That's a big deal, and certainly moving into mail order is something that we're doing. But we're really focused on making sure that I think Skyline's doing is making sure that patients have this great interaction. If they're required to come to our hospitals for whatever reason, they have a good interaction. A couple other things we're working on to develop ambulatory services throughout our market. We do a number of joint ventures. We've got joint ventures with the ambulatory surgery company. We've got joint ventures with a the urgent care facilities. So we've got a lot of urgent care facilities that we joint ventured. We joint venture an air flight organization for the entire Portland metro area. So there's a lot of things that we've joint ventured to make sure that we have number one, a footprint, and number two, a partner that is skilled in doing this work. We know that for example, ambulatory surgery. We know that if we set up our own ambulatory surgery centers out there, we would put the costs of the hospital in the ambulatory surgery center, and it would not be profitable. So why not get a partner that does this all the time and have them build your surgery center and develop it and develop the physician panel for it and operate it in a way that ASCs are supposed to be operated. So we really believe in that partnering for especially increasing our footprint. We believe that's the right thing to do. One more thing that I think is important as we think about building on the telehealth side of things. One of the things that we're focused on with telehealth is actually moving towards a concurrent referral model where our physicians, a primary care physician, can see a patient in their facility, in their office, and get a consult with a cardiologist or other physician while the patient's in the office. There's some challenges associated with payment. We think those will get ironed out over time, but having that concurrent consult is such a huge satisfier for the patient. And it also keeps more patients in your network, right? Because if a physician has a physician, if a primary care doctor has a specialist that they can see on on telehealth, they're not going to refer that patient outside of your organization. So it's a great magnet to keep patients in your organization as well. You get a lot of spin-off business from that. So just all of those things, I think, together are really innovative ways to drive more revenue into your organization. And we're pretty happy with what we've got so far, and we think that there's a lot more to do there.
No, I mean, it sounds like it, and both of you kind of talked about having these kind of multifaceted strategies where you're hitting different areas, right? It's interesting. We've actually found a lot of the same stuff that you're describing. We've been also trying to drive people into our specialist, trying to see if we could get concurrent visits. And you mentioned primary care. one thing we've found, and I don't know if any of you have found this at your facilities as well, is in trying to build these models, we've used primary care as kind of like a central hub, because the primary care doctors can kind of pivot, even things like behavioral health. They can answer basic questions about them and then help drive them into things. Are you doing a similar model where you're centering primary care, or are you doing something different?
So our primary care physicians we locate them out in the communities, right?
Sure.
And then specialists are all located around our hospitals in our medical office buildings. And we think that's the model that patients like. If they need to see a specialist, they can certainly do it via telehealth or come into a facility to see the patient. So yeah, we have a more I think a hub and spoke model with our primary care.
Yeah, but it seems like that's the intake point, and you're
They
using
are
them
the intake, yes, they
together.
are the
Yeah,
hub.
yeah. I think that works very well, especially if you have the right kind of primary care providers. So I mentioned I'm an internist, so it's one of my pet peeves when there's primary care doctors who just send everything to a consultant, but when
Right.
they're able to pivot and handle the initial part and then get into the consultant, it works really well. So no, that's excellent. I think that's fantastic, and you're really talking about finding like new ways to drive revenue, and in general, like I think that there's a lot of innovative or less obvious methods to bring in new revenues. Anil, have you had any
Yeah.
experience doing that?
Yeah, so a couple of things. One thing is, as we were looking at our memo business, and we realized that again, as Ron said, we only offer services from 8 to 5 or something, not convenient for the hospital staff, but not for the patient. So we decided, and we really looked into how long does it take to get an appointment to get a screening memo done. 3.5 weeks. So we challenged our imaging director, what can we do different? So we are going to expand our hours in the evening and one Saturday a month, so that we can accommodate patients quicker and meet their needs. And also, we don't lose those patients to somebody else, because if we can do them in 3.5 weeks, maybe they'll go another imaging center and get them faster. So that's one thing we're doing. Is the second area we'd like to expand, and again, it's a GI availability. It's colonoscopy on Saturday. I live in Brentwood, Tennessee, Nashville, and there's a GI doc. He does Saturday colonoscopy. He's a good friend of mine in Columbia, Tennessee. So I don't mind driving 45 minutes to get that done when I need it to. So I think that as we're looking at a GI coverage, and we had a doctor who was interested in doing Friday, Saturday, and we say, hey, can you do Thursday, Friday, and I say, can you do Saturday also, so that we can meet the need of our patients? I think that's something we really struggle, is we wanted things in our schedule and not patients, and we really need to be thinking about that. How do we meet the need of the patients? And the other area we're kind of exploring is the remote monitoring. We found out that the state of Texas will reimburse you for remote monitoring, and a physician's office can bill on a monthly basis if they're Medicaid and Medicaid secondary. So we're going to, and we have a company who provides the kit for checking your blood pressure as well as your blood sugar. So again, we're going to partner with them and allow our patients to have a remote monitoring, so that if their blood sugar goes up or down, really, so they could be say, hey, the alert comes in and they go see the doctor. And the same thing with hypertension. So those are the two areas we kind of feel like there's an opportunity to add additional revenue for our physician practices, as well as provide a better care for our patients, because we don't want them to struggle if something goes wacky. So that's another area we're working on it.
I couldn't agree with you more. I mean, you hit on what's some of my favorite things, which I call them like the triple wins. Like the patients are happier, they're getting better care, and financially you're
Bingo.
doing better. Like what else could
Yeah.
you ask?
What else? What else you
Like,
want?
yeah, what else are you gonna look for, right? No, I mean, I think you're so right, and Ron was as well earlier about the hour stuff. I started my career as a hospitalist. I was one of the early hospitalists, and I remember when I was trying to sell doctors who were used to seeing patients in their office and then coming into the hospital on switching over to us. A lot of them would complain that they would look at their breakdown of their billing. They're like, well, I make a good amount of my money from my inpatient visits, but what they weren't realizing is when they switched over to using the hospitalist, they used to come in one Saturday out of four and that kind of stuff, and they didn't add that on in outpatient visits. And I was like, you'll make more money per hour actually if you do that. And the first people who figured this out, I think, were the pediatricians. I will never forget when our first child, our son, was 6 months old. There was a night where he had a very high fever. It was a Saturday night. I'll never forget. It was 2 a.m, and he had this high fever and it wouldn't come down. And we called the pediatrician's office, and we were going to bring him into the hospital or something like that. And the pediatrician said no. Told us a couple of things to do to just cool stuff off. He said, I'm going to be in the office tomorrow morning. It was Sunday at 8 a.m. Come in, I'll see him. Brought him in. He had the flu. We gave him the medications. He did fine. He stayed home. He recovered really well. Everything was great. And I thought about it and I was like, if it were me, they would have sent me into the hospital. I would have got admitted, probably would have gotten a DVT in my leg. Something else would have happened to me. And it just, by building it around what's good for the patients, like the care was better. We were super happy with it. And it really was just reallocating our time into the right spots in order to provide those services. We've been trying to do the same thing, opening up services on Saturdays, early hours, late hours. I think it's fantastic. Ron, I saw you nodding a lot during all of that too. I mean, do you have any extra thoughts?
Well, no, it's the better improve the care, right? How do we deliver the highest level of care? Ambulatory blood pressures is one of those cases that we've been engaged in now, I believe, for 3 years. And what we're finding is that people really don't necessarily need to be on antihypertensive medication, because when you measure them in their natural environment, that their blood pressures are not elevated. And so that also, I mean, while it increases revenue, it delivers a better product. Because as a consumer of healthcare, I don't want to be on any medications that I don't have to be on. And so, as we expand into those spaces, we have CTs open until 10 o'clock at night. And which is great for working adults, right? I mean, you can get the kids their dinner, you can go get your CT, you can do all the things you need to do and be ready for work the next day. So you're not interrupting life. And that's really kind of our focus, is trying to, how do we create better access for our community to seek out the healthcare that they need? Because if you're putting that off, you're running some risks. And so it does deliver better care by some of these innovations and just looking at it different.
Yeah. No, and I think the remote patient monitoring is such a part of the future too. I mean, you've both hit on it. I think that we've only begun to tap the surface of what we can do with those things too. I mean, we've already doing basic stuff. I just can imagine other things. I mean, in general, I think we've been having a nice conversation. I think that there's also always stuff though that we're not fully anticipating. Do any of you see any particular hurdles that you think we're going to need to circumvent coming up, or other places where you're looking for insight from the rest of the panel? Carrie, I see you looking to talk, so.
I as I think about it, the biggest hurdle right now is we don't know how things are going to be paid for in the near future, right?
Yeah.
And I'm just talking about mainly federal and state government payments. We just don't know, and there's a lot of uncertainty around that. But my opinion has always been the payments will take care of themselves over time. Do the right thing. Live your mission of your organization, and really be sensitive to the needs of the community, and you'll be successful. So I think all of this swirl that's going on in Washington and in state governments, that there's a ton of it going on right now. We just need to kind of stay focused, stay engaged and really listen to our customers, listen to our potential customers, and really focus on delivering the best and the highest quality care in the patient's location, not our location, if we can, and really approach it from the patient's point of view. I think we're going to be successful in driving additional revenue into the organization.
I think one thing is that Gary said, I want to just say, is we need to make sure we're getting paid. We have a good revenue cycle operations
Yep.
of dealing with denials and underpayment, because that's something we're finding out. I found out this week that there was a patient coming to our hospital for some injection, and the cost of that was like $7,000, and he was getting it done by home health before. And as we looked into the total cost, it was about $130,000 for what we spent on her, and we had several denials and several underpayments and all those things, and it was not caught by anybody else until I brought it up. So I think also having a strong revenue cycle to make sure you're getting underpayment, and when or denials and those type of things are captured timely, it's going to be also critical, because that's going to take care of your revenue part Kerry was talking about. If you just get paid for the services we're providing and not have to fight with managed Medicare and managed Medicaid programs on a daily basis, that's one of the things I feel like it's killing us, is the amount of effort it's taking. And I know it's not a revenue cycle, but amount of effort it's taking to collect the services we provided.
Yeah, I couldn't agree more. We've run into the same thing. I saw everybody nodding. I'm sure everybody would say the same thing. It's just between the uncertainty on the governmental level and the private insurers tightening the screws. And to your point, like, just making sure that we're dotting our I's and crossing our T's and hitting everything. Have you tried anything in particular to try to catch any issues with it? Like, I know some places are trying to use technology in some ways to help supplement it. Is anybody doing that in their places, or?
We are just looking to head down that pathway, to streamline the process for billing, for coding those, and really looking what's out there, because what we do know is, regardless, that I'm guessing that the payments and the systems, whether that be government or commercial, is not going to increase, right? And so we have to find ways to be more efficient as an organization to meet those needs of our community. And I think that is key, is just trying to use the technology. It's interesting, in the nursing world, we always talk about shortages and stuff like that. And so actually saw an article from 20 years ago, and they were having the exact same conversations we're having now about nursing shortage, we're not going to have enough, all of those things. And so I see these themes as just recurrent, and we're pretty innovative, and we find a way through it. Although stressful, it's just, how do we step into the future and do the right thing for our patients and deliver the care and provide more of a well care versus sick care?
I totally agree with you. It's funny. I have this thing I sometimes say, where I started medical school in the 1990s, and I remember back then it was, capitation and all of these things. It's going to change everything. It's so chaotic. Everything's changing all the time. And then it was the death of the capitation era, and everything's changing. It's going to change all the time. And then it was Obamacare, and everything's going to change, and the ACA, and then it was COVID, and that it's a constant state of chaos. So I think the question becomes, like, how do you make yourselves nimble and keep yourselves ready? I think what Kerry said previously, I think, is really smart, is, you try to keep true to your mission, and just, what we've tried to do, I don't know if other people have tried to do something similar, is we've tried to, stay true to what we're doing, but keep our ear to the ground to see kind of where the rumblings are coming, both with data and with anecdotal stuff, and just try to set ourselves up so we can pivot and go into multiple different directions. We've tried to to set ourselves up into areas where we can take what we're good at and move it potentially in a different direction depending on how the market goes. I don't know if other people have tried similar things or have any experience with that.
Well, with being rural, recruiting is one of our biggest issues, right? And so, while this isn't about the business of healthcare, it really is about the recruiting to healthcare. And so, one of the things is we're actually engaged with our junior high kids. And we have a couple innovative projects. One is called a Unit Ambassador, where we allow kids that are 16 and older to come in and actually experience healthcare. And so that we can help guide them if they find that interesting on a pathway forward, even into the colleges and through education, because that's how we set ourselves up for success in the future, is ensuring that we have people who are bought into the mission and, again, driving care for our community. And so while that's not like on the billing and aspects of it, it really is about operation and continuing to have a good pipeline or a solid pipeline of healthcare providers, whether that be in IT or radiology or doctors and nurses, but really building that pipeline so that in 5 years, 10 years, we are ready to move forward and we have that pipeline built.
I think you're completely right. And it's all related, right? I mean, I think the last few years taught everybody, like if you don't have the operation set up and you're not recruiting well, it's going to affect the finance, that they all interact with each other, right? So no, I think that that's super important. It's something that sometimes people forget about, is you really need to make sure you've got the talent coming in and you're developing talent too. You're taking the talent you have and raising it up through your system to get them ready to do other things. We've really tried to focus on that here as well, and just set ourselves up to, take people we see as talented, try to develop them, use them to bring in new people, and try to find, potentially new lines of service building off of that, because those are the people who are out there in the community, the ones who kind of know what's coming. And it's interesting, you can kind of go back to the data sometimes with something they're telling you and see if it's there. And sometimes you find interesting stuff. Like we've had it happen so many times where somebody came to us and said, we think that this is what's going on. And we went and we looked for it, and it's there in the data, but you wouldn't look, but unless you were looking for it, you wouldn't have found it, right? So it's an interesting thing. Sometimes people say you look to the data to tell the story, but sometimes you also look for the story that's in the data, right? Like it goes in both directions. So I wanted to ask, just going around, is there anything in particular that I'll ask, that you're each particularly concerned about, just in the next particular years, or that you'd like to ask for the rest of the panel, for advice on, or something you're concerned with or working towards?
I'll go ahead and start. I think concerning is definitely the talent pool is a real concern. And one of the things we're doing is that we have a nurse internship program where we have like 20 nurses, and they're going through the nurse internship program, and the state is funding half the cost of that program. So I think we're able to do that. But the biggest concern is the talent, and also at every level. So, even an executive level, trying to find a CFO or trying to find a CEO who knows what they're doing, or, those type of things. And the second area is a physician. For instance, we had a GI doctor who's 70 years old retiring, and trying to find a GI in a rural market, and trying to find a GI in any market is challenging. And amount to find it in a rural community is significantly challenging. So our biggest struggle is, how do you partner with bigger places? And for instance, I connected with a doctor on pulmonology who is in Dallas. Say, hey, can you provide a remote or telemedicine services so that we don't, last 2 months, we transferred out 22 patients due to lack of pulmonology. So we're just trying to see, how do we capture additional resources or physicians and that type of thing, because that is what's keeping us awake at night is, how do we keep it going for next several years, and how do we attract the right kind of doctors and the nurses and staff? And so recruitment, both in the hospital as well as physician, is a major challenge, and in coming years, for sure.
Yeah, no, I agree with you, and then that is where we are right now, right in that rural space, and I think we see it as strategic partnerships. It is about, and
Mhm.
I see some models kind of defining themselves where you have a group of specialists who are working together, and they're serving multiple hospitals, right? Not in just
Mhm.
one geographical area, but across multiple areas, because urologists. That's one of we've had an
Oh
opening
yeah.
for about 2 years and have had no applicants for it. But how do you do that in the future as one's getting ready to retire? And so my bigger concern also is with nursing because we have two nursing schools here. One's a ADN and one is a BSN program.
Mhm.
About 70% of the educators in those programs are set to retire in the next 3 to 5 years. And so, how do I build that, and how do we work as a community, not just Sky Lakes, but as a community, to backfill that and have those educators there to ensure we have a supply of nurses. So,
Well, I think this has been a great conversation. I wanted to just give everybody a chance to have any closing thoughts and bring it around through the group. So I'll start with Carrie. Do you have any closing thoughts or points?
Uh, just a couple. Like I said earlier, follow your mission and make sure that you have your ear to the ground with your data, financial data, patient data, and that you're looking around the corner to see what's coming. If we're able to do that, then the revenue growth will come and the organization will be on sound footing for years and even decades to come.
Fantastic. Anil, any closing thoughts or points?
I think the key thing is we as a leader need to make sure we mentor our uh, folks under us so that they can take the torch and move forward with it and teaching them the right value system, right priorities, and also it's been an exciting journey. I've been in this journey for 45 years, and I'll probably do it a few more years. And that's one thing for sure is what the problems we tackled 20 years ago, we're still tackling now. And I just think that we need to really grow our staff and resources to continue to provide services in many, many years to come.
Great. Ron, you're going to have to follow that up.
yeah, no, it's very easy to get into a negative mindset. It really is about payers and staffing and all the things. But I really see this as an opportunity to redefine healthcare. And I know we've been dealing with some of the same issues over the decades and even centuries, I'm sure. But it's an opportunity to usher in AI. It's to redefine models of care and just look for new approaches to deliver great care to our patients.
I can't think of a better way to end this panel than that. So thank you all. It's been a pleasure speaking with you all this afternoon, and have a wonderful day.